So we are happy to have the Ferenc Kuhn. Is the meeting is done only because I want to take advantage of him. He came to see only the tigers and the tigress, but I made sure that he gives us his knowledge to us, and he readily agreed. And from morning to night, he is going to educate us on ophthalmic trauma. Yes? What, do you want something? So he has 360 publications, 7 books, over 2,000 talks across 67 countries. Not bad, I have only 2,600. And Dr. Kuhn has received numerous awards and grants, including from the CDC to develop the ocular trauma score. He serves as editor and reviewer for numerous medical journals and has performed live surgeries in 17 countries. And I think he's a PhD, and plus I think he's first of all, a great human being, and is willing to teach. I don't know how many of you understood. He was telling all the young people here, learn to question your teacher in a nice way, and if the teacher doesn't answer, go to another teacher. Yeah, because that's the experience we had as a student, but I had an excellent teacher, Dr. Badrinath and Dr. Jovanovich. They answered all the questions, and that's why we love to answer any question, and any of the youngsters can take up the mic, and you can tell the old people to shut up, and we will keep quiet. You can ask questions to Ferenc. Thank you, Ferenc.
Thank you very much for the opportunity. So I have 3 talks. I just want to tell you I will make this one and the third one a little shorter, so I can spend more time on the cornea, because to me that's the most important thing. So timing is really a crucial issue, and remember, this is the easiest one to control. When do you do what you do? Here is one case when the surgeon decided there was no injury that he needed to attend to, and you saw that it was a gigantic rupture. So when you talk about the damage an injury causes, there is an initial one, the mechanical damage. Then you do your intervention, when do you, what, and how. And finally, there is a third component, which is the reaction of the body to the injury. So I will talk of all these only about timing, and I will talk about only open globe injuries, not closed globe trauma. If you have endophthalmitis or it's a high-risk case, there is no option. You do immediate surgery. But with all other cases, you do have options. So typically, this is what happens in the world again, because this is a dogma in the textbooks. You do a staged approach, which means you do not 1, but at least 2 surgeries. First, you close the wound. Hopefully, this is done as soon as possible. Don't wait the next day. Do it, if possible, as soon as the patient comes and is able to undergo surgery. And then you do a second surgery. This is the intraocular reconstruction, whatever is wrong inside the eye. Textbooks will tell you this is done roughly around day 10. Textbooks tell you that. But the real world is very different. As I travel to many countries, to many ophthalmology institutions, the real world tells you that the wait is much longer. I need the sound. There is sound for the video, and so this is what waiting does. But if your timing is off, terrible things can happen. And inside the eye, this is the typical consequence of waiting too long. What you see here is incarceration of the retina into the wound. So what happens if you have incarceration in the wound? Here is a typical image that you see. The surgeon does vitreous removal, finds the incarceration site, the potential incarceration site and then does laser around it. And if you do that, what is going to happen? This is what is going to happen. The retina will still be incarcerated in the wound. So now you have to do a lot more when the retina detaches to try to reattach this. And then if you wait more, the typical image is what you see on the right and the surgery for it on the left. The retina is detached everywhere, and it's a closed funnel which is incarcerated in the scleral wound. I saw one child who had this on day 5 after the injury. Typically in children it comes much earlier than in adults, but it can happen within 8 to 10 days even in adults. So if you see an image like that, it means even if you are the best surgeon in the world, you are going to get married to that patient. Why? Because you do surgery and the PVR, for those of you who don't do retina, PVR is our greatest enemy. It stands for proliferative vitreoretinopathy. Basically, it's scarring in the vitreous cavity. So you do surgery for it, but the PVR just comes back. And in certain injuries, the risk of PVR is up to 89%. So you can do two things. You can pray that it does not come. And I've seen many surgeons around the world, as I said, who waited and waited and waited. And when I asked them, why do you wait? And the typical answer is, I was hoping that it wouldn't come. If you're a surgeon, you don't hope. You do something. So you have two options which are superior to the traditional one. The first option is you do a primary comprehensive intraocular reconstruction. If I see the patient first who comes in with an open globe injury, I will close the eye and continue and do everything in the same session. Now, I understand that for that, you not only have to know the back of the eye, not only the front, but you also have to have the infrastructure. You have to have the operating room available. You have to have a trained nurse. If you don't have a trained nurse, don't do this, because you don't want frustration by telling the nurse, give me something, and the nurse says, what? That is not going to contribute to the success of the surgery. But if you have those tools available for you, the best option is to do primary comprehensive reconstruction. But you have another option if you can't or won't be able to do that, which is the same traditional approach. Wound closure and maybe hyphema removal on day 1, and then the secondary reconstruction, but it's not 2 weeks from the injury. It is within the first 100 hours, 4 days. Why? 2 reasons for that number. One is if the patient comes Friday afternoon, you can do it Monday morning. But more importantly, because roughly 4 days is the cutoff after which the risk of PVR dramatically increases. So that's when you do your secondary intraocular reconstruction. Because, as I said, your goal, or one of your goals, is to prevent PVR. The only real argument you have against doing this is what you see on this video, where you don't know what you are doing. You just do reflex, which is, there is some prolapse tissue here, and let's remove that. That's not the way to do this. So this what you saw is a typical expulsive choroidal hemorrhage occurring on the operating table. But if you do your surgery properly, which means you maintain the intraocular pressure, the risk is very low. And if you do a vitrectomy and you do have, very rare, an intraocular severe hemorrhage, you can deal with it either at that time or later on. But nothing else justifies waiting. What you see on this video is a very interesting case. This lady fell in a hospital and sustained a blunt object rupturing the eye. They called me from that hospital and they said, what should we do? I said, put the lady in an ambulance. So what you see here is 8 hours after the injury. There is a 360-degree retinal tear. So if you wait and not do surgery within a few hours, but wait a week, by the time you do the surgery, the retina again is a closed funnel, incarcerated somewhere in the wound, and it's a much more difficult surgery. You have a much higher risk of recurring problems, and the vision, of course, is much worse. So what I was discussing so far was what to do with the eyeball. But my biggest problem with this mentality is not this, it is this, because we are not talking about an eyeball. We are talking about a person who has an injured eyeball. And typically nobody cares about this. The books will never mention that there is a person attached to the eyeball. So imagine yourself with a condition. Do you want that condition to be solved now or sometime in the future? Obviously now. Why? Because normally you would worry during that period, stress, what happens at the end of the process. If this is not obvious, let me tell you an example. Let's say you are a patient and you undergo cataract surgery. Your friend will do cataract surgery on your eye. There is music in the operating room. The surgeon is asking the nurse, give me this, give me that. And then the next word, and I'm sorry, I have to tell you how it happens in life. And the next word you hear is this, shit! What happened? This is what happened. Your nucleus is in the vitreous cavity. So if you look at the literature at this point, the literature is divided. One part will say you can wait 2 to 3 weeks until the eye is not inflamed anymore, or you can do surgery now. The results are the same. I don't believe that quite, because if you have this in your eye for weeks, you will have cystoid macular edema, which requires additional things and may not recover vision fully. But let's say it's true that it doesn't matter in terms of the final visual outcome, whether you did or your colleague did the vitrectomy for this condition now versus 3 weeks from now. How do you think you will spend your next 3 weeks waiting for the ultimate solution? Are you saying it doesn't matter, or you say, I'm a little worried? Of course you're worried. So one of the reasons to do early surgery is to allow that patient to have a shorter period of anxiety between the injury occurring and the ultimate reconstructive surgery. So in summary, what are the benefits of waiting? The answer is easy. Nothing. There is no benefit waiting with your reconstructive surgery. But doing early surgery means, one, it's easier technically, and two, you prevent a lot of complications which otherwise would come. So don't be late, because if you are, this is what happens. This is a bank robbery, true bank robbery in Detroit, that somebody recorded. You have to arrive on time. Thank you.
They arrived on time, but they didn't do action.
Any questions?
Thank you, Dr. Kuhn. Thank you, Dr. Kuhn. That was a wonderful talk which you had given us. And the best thing about the talk was the very humanitarian approach that you have propagated throughout your talk. And also a very important take-home key point that do not wait for 14 days as is advocated, but do it as early within the first 100 hours. Thank you so much for these pearls, Dr. Kuhn. Any questions?
Some youngsters should ask question here. There are a lot of young people. Mansi, you want to have some question? Smith. Sunil, you are the youngest here.
I wanted to ask Dr. Kuhn a question. He mentioned something about his corneal, about not using the forceps. Sir, could you highlight on it, please?
If I may defer it until my talk,
Okay,
because I will spend time on explaining why you do not need and actually should not use forceps when you suture corneas.
Hello.
Yes.
Dr. Sunil here.
Yes.
I just had a couple of questions to ask. The first question would be, when somebody comes with a detached finger, we tell him that this has to be attached as early as possible. Mm-hmm. Somebody comes with a retinal detachment, wouldn't the same analogy apply there? Or somebody who comes with a tear, most probably one of the reasons is probably because the vascularity is important here, but in a corneal tear, it's a neovascular tissue. So would you, instead of 100 hours, say as early as possible as the first dictum, or would you still say that no, I mean, you may delay up to 100 years, 100 days?
Are we talking about a normal retinal detachment, not
or
a
traumatic,
trauma?
or traumatic,
Yeah.
or any?
So there is difference between the two. Trauma, usually you don't have a detached retina at the time of you first see the patient, usually. So the reason why I recommend early, and again, as early as possible, the 100 hours is the maximum, is because the signal to the body to start the PVR process is there. So you don't do the intraocular reconstruction to treat retinal detachment, you do it to prevent scarring, basically. It also helps other ways, because obviously there is no blood, you can see the inside of the eye better, the patient's vision instantly gets better, etc. If you talk about a normal rhegmatogenous retinal detachment, my philosophy is that's not an emergency surgery. So that's not, you stop the daily routine, or you come at 8 o'clock in the evening and fix it. Because even if the macula is off, if you do it next day, the visual function can be, it's probably going to be just as good as doing it at the moment. So with that, you can wait a day or two.
The second question was, how important would it be for each individual to actually get himself audited by somebody else to look at these timings issues, that I operated this patient this time and this is what the outcome is, and how would that guide it?
So The problem with doing a so-called level 1 evidence study in trauma is because you can't standardize it. You will never have equal injury groups on the two sides. So you can't directly compare the early versus the delayed. You have to have a huge number of patients on both sides, and you think that overall the injuries are similar. So this is one of the many examples, especially in trauma, where common sense rules. And common sense tells you that, well, common sense and again clinical experience, because I can tell you as I travel and people bring me charts to ask for my opinion whether what they did was right or not. And I look at the chart and I see the first surgery, and then I look at the second surgery's date, and it's 3 weeks, 4 weeks. And I instantly tell myself this patient will either have PVR by now, or even after the second surgery is done, PVR is coming, and it is coming. So, again, common sense and experience tells you that waiting does not have benefits. It's exceptionally rare that a patient with such an injury will not have PVR. And if you can do early surgery, first of all, as a general rule, early surgery means easier surgery. The only caveat here is corneal transparency. That's why what I will tell you about the cornea does make a gigantic difference. So very briefly, I'm not going to go into that now. I don't do 90%. I do 100%. My suture is in the anterior chamber, which means by the time I finish suturing the cornea, my cornea is clear. I will be able to do everything in the back, everything, including peeling the ILM, because my cornea is fully transparent. So if you can do it now. And I'm not saying you will not have PVR, but the percentage of eyes with PVR with an early surgery is much lower than with the delay.
And the last question, if I have time. Yeah. So the last question is that doesn't this bring to a point where a lifelong support or a lifelong coaching of somebody senior is essential, even if I were to achieve a standard of being an expert in inverted commas. So I learned from Dr. Kuhn, from your books in the past. I started teaching my students, but now I see you've evolved at least 100 times more than what I thought is what you wanted to say. So is lifelong support to the students important, and should the students actually seek lifelong support?
Well, we all of us, including me, will learn, or should be able to learn. In other words, we all are students and teachers at the same time. The older you get, you're less of a student, but you are still a student because you always see something that somebody does that say it helps. But after some mentorship, being under some mentorship, and starting doing more and more on your own, eventually you reach a point where you don't need somebody sitting next to you all the time and coaching you. So I cannot tell you when it is because it depends on many factors, but once you have enough experience, you will have only occasional questions what I should do in this case, and you will do a very good job on your own. Okay.
So I was referring to Atul Gawande's lifelong coach. Cricketers, footballers, they still have coach even if they are the gods of cricket. So
No, you don't
afterwards-
need a lifelong coach to answer with a one word. No. No. Yes.
That was an excellent presentation by Dr. Kuhn. As you aptly say, timing is everything. May I request Dr. Robi to please present him a small memento? And
Oh, yeah.
Yeah,
Okay.
sure.
Okay.
Yes.
So in the meantime, what's the name? Sunil, the lesson from being moral from Dr. Atul Gawande, I follow him very quietly, but I have done it with Dr. Jalda Joanich, spending every time he came to India, now he's retired, he used to come watch me operating, but he'll never say a word, unlike Atul Gawande's teacher who came, but not every day. So lifelong coach is not a right word. But you have a coach, you have a mentor. See, yesterday, Dr. Mansi came to me with asking a question about a patient with a trauma, with something. I said I was busy doing something. I requested Ferenc to help and he did it. So the question is, even at this time, we will get some doubt, but you should not be shy. There's no ego. That's what I have learned. I call anybody. And I operated a child where I troubled the best experts in the world. And that patient's mother is so well educated, I don't know whether she's going to come this evening. And she contacted 100 people in the world and all top people. And everybody was finally directed and I operated immediately with a great difficulty because 15 man hours to talk to that family because they're well educated and well informed. So we have to have somebody to tell us, but not all the time. As you said, every time somebody cannot be sitting on our head because it's not an ego. No, lifelong coach means you don't need a coach all the time. So many coaches will observe, they will not tell you. And looking at his face, the student has to learn. Like me, we have to learn from our own conscience. And very time self-education is very important.
And
Yeah, Ferenc.
there is a corollary to this from the other side. Never think that you know everything and never think that you know everything better than everybody else. That's the worst you can do. Yes.
So there are two chapters I would like you to refer. One is the surgical self-education written by Steve Charles in microvitreous surgery, and the second one is surgical self-education written by me in my cutting-edge vitreous surgery textbook, both by Springer.
So my question is, because we are doing a comprehensive reconstruction together and not a staged procedure, would you always get an B scan and all the imaging done beforehand, even in an open globe injury?
That's an excellent question. And before I answer the question, my advice to all of you is never believe a word anybody tells you, including me. Why? Think about what I said and everybody else said and consciously come to a conclusion whether you agree and then do it or disagree and then don't do it. So now my answer is no. Why do I not do ultrasound? Why? I've once had the opportunity of having one of the world's most famous experts in ultrasonography looking at my patients before surgery. 50% of the time he was wrong. He told me there is no retinal detachment, there was, and vice versa. The only thing I really believe is this. So when I have a serious case with vitreous hemorrhage, etc., when you may have a detachment, is I will approach every case assuming that there is a retinal detachment. So I do cautious surgery, not assuming that the retina is where it's supposed to be. That's my philosophy. Okay?
But sir, in cases which we have a lot of vitreous hemorrhage, so all those cases you would try to clear the vitreous hemorrhage immediately? Or you would clear the vitreous hemorrhage only if there is a pre-existing retinal detachment?
No. Traumatic vitreous hemorrhage is an enemy. For many reasons. One, you don't see what's going on inside the eye. Two, it's an inducement for PVR to occur. Now, technically, there is, again, I'm sorry, I'm spending time on some, on things that maybe I shouldn't.
No, it's
Yeah.
fine, because the whole idea is we all want to learn from
Okay.
you.
So again, here is what the literature tells you, because I have to stop before I explain that. When you have vitreous hemorrhage in an older diabetic patient, it's very different from a young patient's formed vitreous having blood in it. It's easy to remove an older person's diabetic, whatever, vitreous hemorrhage. It's not easy to remove vitreous hemorrhage from a young person's formed vitreous. So when you look at that young vitreous, because most trauma patients are young, the vitreous is infiltrating, I mean the blood is infiltrating the vitreous. So when you look at the vitreous, for example, you can actually do it if you do open sky vitrectomy, which I don't do because of the risk of further hemorrhage. But if you do, what you see is, first of all, as Professor Natarajan said, you have no idea what you're taking out. You don't, because it's not obvious. So you can be fooled two ways. One is that there is a red streak, which you assume is a blood vessel in the retina which is detached, and therefore you don't touch it. But it's not. It's a streak of blood inside vitreous layers. And two, you can have blood, true blood, pooled between vitreous layers. So you get there, you remove the vitreous in the front, and all of a sudden is this fluid blood everywhere. You said, oh my God, I just got into the retina. And you can be fooled on the other side, which means there is retinal detachment, but the blood vessels have no circulation. Therefore, you don't think and you don't see that you have no visual feedback telling you this is retina, and you can remove a large part of the retina. For these reasons, I don't follow what you read in the literature, which says, in this case, what you have to do is you remove, I'm quoting, horizontally moving your vitreous cutter carefully from anterior to posterior. Again, you have no idea what you're removing. So what I do in this case is just the opposite. I go to the nasal side, the macula is on the other side, and I go and dig vertically. So I'm digging a well on that side, because either I will see that there is retina somewhere in the back, or if I did not see it, I was fooled, and I went through the retina. Once you are in the retroretinal space, you know exactly where you are. You did create a retinal break, unfortunately, but it's on the nasal side, but now you know where your retina is. So technically, that makes your surgery a little easier. Okay?
Thank you so much, sir.
Okay.
Request Dr. Karobi again to present a small memento and to Dr. Kuhn. Meanwhile, Dr. Rao is there, the next presenter. Yeah, she will be present. Yeah. May I invite Dr. Rao to present her presentation on nasoorbital ethmoidal fractures.